introduce Anna Maria Rossetti, because she is a very, very motivated and passionate midwife that very, very young acquired all the long life of work that another great Swiss and Italian midwife had built. The midwife is Verena Schmidt. I think that someone of you will know her opera. So Anna Maria was the best woman and midwife that could acquire the whole burden, but also the whole responsibility to go on in continuing this opera, in let this school, the school founded by Verena Schmidt, that is a referral point for all Italian young midwives, letting this school continue and flourish. Anna Maria has also started from Italy, but has also an international experience. I think that you will hint about this perhaps. And also as opera went beyond the initial research of Verena. So it's my pleasure to give you words and smile, your best smile, to speak to this important meeting. So.
Thank you so much for the amazing presentation. I hope you all hear me well. Yes. Again, I am Anna Maria Rossetti, an Italian midwife, and I am director of the school founded by Verena Schmidt in Florence, and I'm also part of the EPOV Respectful Care project, led by Patrizia Quattrocchi. My presentation is about the salutogenic approach I was taught by Verena Schmidt, and then we developed over the years. My offer, when I was offered to speak at this beautiful event, the grand finale of the Respect project in Cyprus, I thought to use this quote as Salutogenesis as the antidote to obstetric violence. We've been working a lot on this in Argentina for the IEPO project, and I thought that when we are talking about respectful care, we also need to investigate new models of care. So of course, my mentor is and has been Verena Schmidt and others that you will see along the way of this brief presentation. And Verena Schmidt applied the salutogenic model of care, which is a psychosocial model, you will see it, to the midwifery care in a model that she called salutophysiology. And the leading paradigm is that the lenses with which we view pregnancy, birth, and breastfeeding postpartum shape our paradigms of care. It's not midwifery care, is not just an evidence-based medical health care science. It's mainly the reflection of what we feel towards pregnancy, birth, and breastfeeding, both privately and socially. It's also mainly cultural. And the salutogenesis wants to counterbalance the overview on risk factors in maternity care, counterbalancing with the view over health factors. So it's not denying the presence of risk factors, but health factors help us gaining another lens. And the other lens will enrich us with a three-dimensional view over what really is pregnancy, birth, and postpartum, not only for what we read and study in books as health professionals, but for what women and families actually live and perceive. So, salutogenesis is mainly a model that was, with the name is the genesis of health. If we think of salutogenesis, we're going to see in this brief presentation what it is, the theoretical foundations, the practical applications, integrating the salutogenic approach into advocacy, and mainly strategies, research, and policy recommendations. So what is it? Aaron Antonovsky, a sociologist, studied the survivors from concentration camps after the Holocaust. And he realized that given the fact that these people lived a major, dramatic, great, stressful event, some of them couldn't live a life afterwards, and some others could. Some were able to rebuild their own lives, and some were not. They got sick and ill and depressed and suicidal. And so he started investigating how come some people, given the fact that they all lived a big traumatic event, some could overcome and some could not. And so he made up this theory of the coping or sense of coherence. So the capacity of the individual to cope with stressors in life. The sense of coherence that he presents to us is made of three major factors, the three pillars of our health: understanding what is going on, having control and the predictability of what is going on, and third, having the possibility to attribute a deep meaning to what is going on. It could be a faith, it could be a religion, it could be a deep motivation. The theoretical foundations are the ones that want to analyze the risk avoidance basis of our midwifery and obstetric practice, which are based in most countries of any levels of income. It is based on a postmodernistic paradigm. So risk avoidance is not midwifery care, but has become midwifery care. Acceleration as well. So we accelerate the processes, we anticipate women's needs, giving them needs they don't really have, because we have needs of control, of testing, and then we accelerate the end of the pregnancy with inductions, and then we accelerate labor and birth with medical practices, and then we accelerate the moment when mothers will be back to work and interrupting breastfeeding. And so if we look at these theoretical foundations of what has become our midwifery care and obstetric care, we see that there are differences in perceived satisfactions of women and families when we are working with a risk-oriented care rather with a health-oriented care. If we focus on risk, and every person who is pregnant or laboring is subject to the scrutiny of risk, this may impact her level of confidence in herself. If health surveillance, and this I'm quoting, and treatment become a standard or even a morally expected norm in the absence of a concern for human experience and fulfillment, there is a risk that life choices will be determined solely by assumptions about physical risk and pathology. So risk-oriented care versus health-oriented care is the main focus that Salutogenic wants to stress. The risk model of care is focused on risk. The health of the person is delegated to the expert, and protocols and standardization are the rail you get in when you are in this model of care. Power and control are of the professionals taken care of, and so high or excessive use of technology is how this control is mainly exhibited. And the kind of relationship in between the healthcare professional and the families and women are a directive relationship. So you expect a doctor to give you a diagnosis and a prescription. In the salutogenic model of care, the focus is on health factors together with the risk factors, which we cannot deny. There is no delegation because we want women to be empowered in their own decision making. So it's a shared responsibility. The personalization of care instead of the standardization of care, and protocols become flexible. Power and control belongs to women, and appropriate or no use of technology and a supportive relationship. And if we look at what the salutogenic model of care wants to do with women, is exactly what the Ottawa Chart of the 1986 stated. The perception of health is a health factor itself. We cannot say that our choices are free if we are made to perceive ourselves as ill and incapable. So, for sure, we're talking about respectful maternity care. Empathy, sensitivity, non-violent communication skills are essentials, but they are not enough. Because if we are healthcare professionals, we were trained in the risk-oriented model. So even if we don't like it, it is our comfort zone. And so to skip from a risk-oriented care to a salutogenic care, we need to uneducate ourselves in concerning of so many things we have learned to be right and good and essential for the survival of the human species. Practical applications. The World Health Organization recommends respectful care, but even though it has been stressed out a lot, and for good reasons, that birth has, we want women and families to have a positive birth experience, the sentence that really triggered my attention was an assistance that allows women to express their own potential. So what potential? And I really love when a question highlights food for thoughts. What are the potentials of women, pregnant persons, in carrying on a pregnancy, giving birth, and then breastfeeding? Because I was trained by Verena Schmidt, I tend to separate didactically, these potentials in neocortical potentials, which means the fact that we are sapiens, so we have thinking process, we have self-determined decision, we have our culture, the way we perceive ourselves. And then limbic potential, which is directly related with our emotions and neurovegetative system that works together with the environment. And if we want to support and recognize the neocortical potential of women giving birth, we must recognize their self-determination in health choices, because we are neocortical mammals. But at the same time, we have to recognize the physiological potential, so respecting and protecting physiology. And because we are in the world that we know, we want to also protect the residual physiology, which means that it doesn't matter how much is your risk factors, it doesn't matter how many pathologies you have, still, as long as you're not dead, you have a residual physiology. And we will be working on that in a salutogenic approach, so that your potentials will be will flourish the better they can, given the conditions. In these potentials, the environment is a potential as well. And of course, we talk about the physical environment, the built structures, the naturalistic environment. Yes, these are of course things that matter in our physiology, in our biology. But the environment I want to focus on is us. Because if we are attending birth, we are the first environment of that birth. And so, practical applications, we have studies saying that the sense of coherence is entwined with the quality of life. And the more I am oriented, I know what is happening to me, I have tools, and I have the possibility to live deeply with deep meaning my reproductive processes. I also have a greater quality of life towards these processes. And doesn't matter the age, sex, ethnicity, nationality, the sense of coherence is a paradigm of health worldwide. And it can also provide a balance to the current overemphasis on pathology in maternity care design. Practical applications. In this study, it was given a questionnaire in the prenatal and postnatal period investigating the sense of coherence based on the Edinburgh Postnatal Depression Scale and the Support Behaviors Inventory, SBI. And the highlights of this study from 2016, it's a little older, but they say that midwifery attention should be focused on strengthening women's sense of coherence, because sense of coherence is a modifiable factor in women's childbearing health, which means that what we do, the environment we create around families, pregnant women, birth and postpartum, can modify their sense of coherence, therefore can modify their health, starting from the perception of health. Using a case studies from research conducted in Norway, it has been observed that a salutogenic approach, while acknowledging obstacles faced by immigrant women, it was a study of African immigrant women in Norway, would also more fully recognize the strength, resilience, and coping strategies of these women as they navigate pregnancy and motherhood. So they took a population that was selected for being fragile. Immigrant, Black women with a language barrier and possibly economical difficulties and cultural shock and environmental climate differences, everything we know that is the environment around these women. And they support them, stressing their strength, their resilience, and their coping strategies. So implementing their sense of coherence, focusing not on what is not going well, but more on what is going right. And this worked to implement the health results, the outcomes, and this worked also for LGBTQ plus families and for Afro-Americans and natives in the rural areas. So strength, resilience, and coping strategies are the key words. If it works for immigrant women from Africa to Norway, if it works for marginalized groups, it must work also for women who are labeled as high-risk women during pregnancy and birth, or for pathological women, always focusing on resilience and coping strategies. And here we need to add something more. And this is what Verena Schmid added, and I learned how to integrate this psychosocial model with how our biology works. So not only we need to change our model of care, but also we need to restudy a new physiology. Psychoneuroendocrine immunology is a branch of medicine that explains the connections in between our biology and the environment. And the psychological system, neural system, endocrine and immunitarian system are the four, but we have one more system during pregnancy, which is the fetal placenta system. And the fetal placenta system lives in the environment. We have so many modifications on the functionality of the placenta in terms of circulation from the uterine arteries, in terms of production of cortisol and placental enzymes, protecting babies from mother stress, that tell us that a good enough environment and a salutogenic approach can modify biologically the health of a pregnancy. And because pregnancy is the best preparation for birth, can also modify the outcomes. And this we see in all the research that we have publicly in the World Health Organization, that through a continuity of care and a salutogenic approach, not only women and families are more satisfied, but there are actually better clinical outcomes. The fact is that we cannot separate the well-being of the baby in the womb during pregnancy and during labor from the well-being of the woman and her resources and environment. If we think about what Aaron Antonovsky taught us, he said, of course, everyone has different coping levels, different thresholds of coping with stressors, but we can say, generally speaking, that we live in a biology that needs a good stress to operate. Therefore, he identifies two different kinds, qualities of stress. EU stress, from the root EU, which means good, and the distress, so the stress that is no longer good. If we think of a good stress, so we want the respectful care that puts women in the conditions of not feeling overwhelmed and small and hindered by maternity care that focuses these factors and wants to control them. But still, they need and they benefit, they and the fetal placental system, they benefit from a good EU stress. A good stress active the person encourages the activation of the endogenous resources of the person, promotes adaptive responses, boosts health, increase coping capacity. So it's good. And it's always balanced. Physiologically speaking, the maternity reproduction period is balanced towards a new stress, thanks to neuroendocrine modification, both of the patients, both of the neurovegetable system and of the placental hormones that will produce neuromodulation all through the process. To avoid distress, let's think about when the pregnancy starts, for example. In the uterus, the trophoblast starts to munch the terminations of the stress fibers of the sympathetic system, for example, the fight or flight system in the uterus. And along with the pregnancy, the systemic fight or flight response of the person in pregnancy will be reduced. So it will be increased, but it will be more balanced by the parasympathetic system. So all these processes are meant to protect women from distress. So what is distress? Something that challenges the person's resources and overwhelms them in potential or exhaustion. It's often chronic, reduces the ability to cope with pregnancy, with labor, with birth, with postpartum, with breastfeeding. It requires the activation of more and more exogenous resources. I can't do it by myself. I need somebody to help me. So, this is the EFS, a definition of the salutogenic approach to midwifery that wants to activate the person, encouraging the person's endogenous resources, promoting good adaptive responses. And isn't this distress a representation of a risk-oriented approach, challenging the person that will feel unable, incapable, small, and in need for protection, advice, interventions, and so on. So, when we are talking about the potentials of women, here we need to talk about the limbic potentials, which are the physiological potentials that we do not study in books, which is a pity. And not just a pity. We have to imagine that ignoring, not knowing, or even willingly putting aside these potentials is not only not respectful towards women and their processes, but also maybe violent, because we are ignoring that there are psychophysical potentials in pregnancy, birth, and postpartum that if not seen, recognized, they will always be in second place in front of the risk-oriented care. Our brain really gets into the fear so easily, in the trust with less ease. So maternity is cyclic, and cyclicity, says Aaron Antonovsky, is at the basis of learning. So what women can learn from their own processes. For example, the cyclicity of maternity means that the psychoneuroendocrine processes in the first trimester of pregnancy will be the same ones we will see in the prodromal phase before labor starts. And they will be a lot similar to the ones we will see in the first trimester of that gestation when the baby is born. And so the second trimester is very much similar to the dilatation phase of labor and to the second trimester of exogestation. And the third trimester is very similar, psychoneuroendocrinologically speaking, which means the hormones, the cortisol, the adrenaline, the endorphins, the activation, the balance in between parasympathetic and sympathetic system in our autonomous nervous system is very similar to the expulsive phase. And they are both very similar to the patterns that will support the third trimester of exogestation. So by leading these processes with this knowledge, by educating ourselves and giving a chance to family to understand these processes, makes them more powerful. So the power is given back to them, and they are recognized even in their physiological potentials. The model of care of the salutogenic approach has been talked about along the midwifery care model. But there is a challenge, and in this survey from the WHO, it was the first and the last, as long as I know, that was conducted on the health status of midwives, stated that the bottom line is that in societies that do not take into account the complex care needs of women, children and their families, midwives also suffer. The fate of midwives is intrinsically linked to that of women and reproductive physiology. We need a change in policies. We need a change at the very basis of what healthcare professionals, both midwives, obstetricians, study in their books. We need new books. We need new research. We need to invent the research over the physiological aspects of the salutogenic approach and also the psychosocial aspects of the salutogenic approach. And then we need to research more and implement the policies that help midwives powering women. And midwives, professionals will have to learn psycho-behavioral balance and the clinic, and how in face of a level of risk for a woman who may be at risk in that pregnancy because of gestational diabetes or large baby, whatever, being able to put that label into a personalized context. The woman is competent, and the baby is a resource, not a threat. And not only, a baby is a subject of relationship since pregnancy, and is not an object of observation. And one thing that has like a meta message that has come to women that were assisted in the risk factors model is that they perceive themselves, no. They may perceive themselves as a threat towards newborn babies. But if we look at physiology and we empower women as a resource for their own babies, we switch the narration. The narrative changes. It needs to change. And so we need a new clinic. We need to go back using our hands, our clinics, integrated clinics, the listening. We need to create and promote better environments and knowing how to activate the potentials of women and that specific woman, that specific baby, because this is personalized care. So, Salutogenesis for all, midwifery care model based on salutogenesis and integrated biopsychosocial approach is a reference model for the whole society. We could be leading a new way of supporting not only maternity or paternity, but also a new way, a new model to support the global health of the individuals and of society, rehabilitations, surgical, post-surgical fields. And by respecting this approach, we automatically respect women, families, and people for their complex needs. And my wish is that a new knowledge and a new studies and new books lead us into the comprehension that pregnancy is the best preparation to birth, that birth is not an expulsion, birth is a meeting of two persons who are meeting, and postpartum is the result of what came before and who we were in the approach to this family. So I wanted to make it shorter today because I know we are running a little bit and it's a beautiful morning. I didn't want to take time from the others. And so this is where I end my presentation. Thank you so much.
Anna Maria Rossetti, allow me to say that I teach salutogenesis, and I agree with you, and I always emphasize to my students, to my midwifery students, that our face, when we are next to the women, must look like we are here, we are next to you, everything is going to be fine, because we all know that if we interfere our biology, okay, we have a lovely system. Women have a lovely system, okay? And if we allow that system to work, we shall have normal birth. We shall have what the women expect to have. So it's very important, midwives, to work with the obstetricians, and I'm glad that now you will see obstetricians and midwives be together for so many years, to work together, to create what? To create something new, something for the women to, let's say, to improve things. And I am sure that we can make it. But now I am sure that we don't have enough time to spend for this. We can talk about salutogenesis for many, many hours. And we love Antonovsky, and thank God for Antonovsky to found this theory. And Anna Maria Rossetti, thank you. I wish to see you in the future. And we shall continue.
Thank you very much.
And we shall make a more change in our program. Now Branka will be here with us. Branka is a program coordinator. She works in Rota in Croatia, and she was with us. She conducted a survey about respectful maternity care in her country, and now we shall have the opportunity to see what happened in other countries, okay?
Hello, everyone. I hope you can hear me. So I come from Croatia, a small country on its own, but small country on the Adriatic coast, but we have, unfortunately, we have big problems in our maternity care, and I will show you some numbers, and we already heard that numbers are very important, so we will see whether they are important when we hear what women say. So I come from an NGO, Parents in Action, called RODA. It's one of the biggest NGOs in Croatia, and definitely the biggest one when it comes to parenting, when it comes to mothering, maternity care, and obstetric violence. In fact, we were first in Croatia who introduced obstetric gynecological violence in our society. It was like 13 years ago. So today, most of the people already know what obstetrical and gynecological violence is. And now, through this project, we are trying to introduce respectful maternity care and promote this kind of care. So first, let me thank Nicos, Cyprus University of Technology, Birth Forward, and our partners for inviting us to this wonderful conference, and to giving us the opportunity to show some results that might not be interesting to you, because Croatia is a very small country, but I guess that you will see some similarities with your numbers and the situation on Cyprus. Okay, Nicos was supposed to introduce our survey, but I will take a few moments to tell you that the survey that we have implemented in Croatia was the same survey that was implemented in Cyprus at the end of 2023 and the beginning of 2024. So I will show you Croatian results, and then Nicos will compare it to the Cyprus results. So in Croatia, in total, 855 women participated in our survey, and plus there were 11 women who participated in focus group discussions. So most of the women, they had single pregnancy, they are Croatian, and they gave birth in public sector. We have a quite different healthcare system than yours here in Cyprus, so most of the women go to the public hospitals. Only one small number of women go to the only private hospital that is located in the capital city of Zagreb, and even smaller number of them decide to have a home birth. So as you can see here, 65% of women who participated in our survey, they had vaginal delivery. 20% of them, they had the cesarean section without general anesthesia, 10% with general anesthesia. 3% they had instrumental vaginal delivery, and only 1% had vaginal birth after cesarean. So those numbers reflect the current situation, almost 100% that is in Croatia right now, because the number of the rate of the cesarean sections is rising, and at the moment it's close to 30%. Okay, so let me show you only some of the results. So the rest of the results you can find on internet. So I will walk you through this survey quite quickly. As you can see here, 50% women said that never or a few times their healthcare providers did everything to help them manage their pain during childbirth. 60.2% of women said that never or a few times their health providers supported them in creating comfortable birth environment. 78.8% of women said that never or a few times their healthcare providers asked them about their emotional well-being. So we are talking about numbers, and those numbers are quite big. Okay, so 36.7% of women would say that never or a few times they were treated with respect. 40% of them would say that they never or a few times that their healthcare providers kept their health information confidential. And 43.6 women would say that their healthcare providers never or a few times took the best care of them. 56% of women said that never or a few times were informed what was happening with their body during their childbirth. 61% of women said that never or a few times they were heard and listened to by their healthcare providers. And 72.6% of women said that never or a few times their experience and the knowledge were valued by healthcare providers. Okay, now we can see that 17.4% of women experienced at least a few times physical abuse. We are talking about handling them roughly or physical restraint. 31.2%, 9% of women experienced at least a few times verbal abuse. 51% of women experienced at least a few times neglect. They were avoided, they were ignored during having a childbirth. 67.5% of women said that never or a few times their healthcare providers used the language or words they could understand. Nearly 76% of women said that never or a few times their healthcare providers explained examinations or procedures that were done on their bodies during childbirth. 82.3% of women said that never or a few times healthcare providers checked understanding of the information they gave to them during childbirth. And some more numbers. We heard about birth plans. So here we can see that nearly 69% of women said that never or a few times their birth plan or preferences were respected. For example, 77.3% of women said that never or a few times they were involved in decisions about their care, about their bodies during childbirth. Nearly 78% of women said that never or a few times they were asked for permission or consent before they were touched or some procedures were done by healthcare providers. While making decisions, 43.6% of women felt not comfortable asking questions. 45.7% of women felt pushed into accepting options that were offered to them by their doctors or midwives while making decisions. Almost 40% of women held back from asking questions or discussing their concerns because their doctor or midwife might think they are difficult. 26% of women held back from asking questions or discussing their concerns. They wanted different care from what doctor or midwife recommended to them. Here we can see something that is referring to informed consent we heard a lot about today. So for example, induction of delivery, 8.2% of women said that the induction of delivery was performed without their informed consent. 18.5% of women said that the episiotomy was done without their informed consent. In vaginal examination, almost 13% of them were done without women's informed consent. When it comes to mistreatment and how women experienced it, 13.2% of women said that they were threatened in some way by their healthcare providers. or almost 40% of women said that they were forced to remain in uncomfortable, painful position during their childbirth. 22.7 were shouted at or scolded during childbirth, and 16.9% of them heard some offensive or humiliating words. 28.2% of women were ignored, refused, or failed to respond to requests during their childbirth. So as you could see on the last two slides, in total, 64% of women reported at least one of the listed experiences, and most of them experienced 2 or even 3 and more such experiences, which made us think that the education of all who are involved in care for a pregnant woman and childbearing woman is very, very important, but not only for them. The education is very important for everyone who is providing such a care, but it is also essential for women to be empowered, to be informed, and to take course of their own childbirths. So I will tell you a bit more about how we and what we did in this project, how we educated healthcare providers and women, but I think it's later on our program. Yeah, thank you very much.
Thank you, Branka. There will be some discussion later. Now time is gone, and Nicos Middleton, that you already know, because he's one of the animators of this important meeting.
I'll keep that. I like that.
Professor, associate professors in based methodology and biostatistics, member of the Birth Scientific Society Committee of this Cyprus Epidemiology and Public Health Association, and obviously is a very important member of this association that will forward and all the building of this enormous and important project. It's okay for you?
Absolutely. Thank you very much. What I'm thinking now, though, is that we ruined your coffee break.
Yeah.
And I wouldn't want to ruin your lunch. So we had prepared the same presentation as with Croatia to show you the Cypriot results bit by bit, domain by domain. Many of you may have seen them in the previous stakeholder meetings. So I will need to improvise again. Allow me my 10-15 minutes anyway to choose some key results. And I think instead of showing numbers, because we saw some numbers, and I can tell you that the numbers in Cyprus are not quite as bad as Croatia, I will prefer to bring the voices rather than the numbers. So I will focus more on the focus groups and the interviews and the way the women described the experience. There's 2 ways of doing that. One is going through a presentation, and the other one is to show for the first time, screen for the first time, a video, an educational video that we made for healthcare providers entitled "When Standard Practice is Not Practicing Standards." I will opt for the second, once I show you some of the numbers to compare with Croatia. I will opt for the second, and I will pause the video and I will read the quotes, the words of the women in the Respect survey that shaped this story. So the story you're going to see is not one single story. It's the pieces of the puzzle of the many stories that we put together to make a story that could be the story of one person. Let me first say that the results you saw from Croatia, yes, it was the same survey conducted at the same time, both in Croatia and Cyprus. And of course, we had to translate the 7 rights of respectful maternity care. We had to give them an operational definition, as we say in methodology. We needed to find questionnaires that can actually measure those rights. There isn't one single questionnaire we could use. We had to use 4 different ones to tap on every aspect of those rights. These are the questionnaires. We didn't create these questionnaires. They are internationally used questionnaires, so the results that we get are comparable with results in the literature that have used the same questionnaires. While we were conducting the RESPECT study, Cyprus participated in the Imagine Euro study. Croatia had done so previously, so there were already results from the Imagine Euro study. The Imagine Euro study is the biggest study across Europe on respectful maternity care. It's more framed about quality of care, and their questionnaires are based on the WHO quality indicators. Cyprus was the only European country not in this consortium until RESPECT started. So we opted to jump on this study as well because we wanted to see comparative results between Cyprus and the rest of Europe. Now I'm focusing on the RESPECT survey, and I showed you 4 questionnaires, but I'm only going to focus on one, which is called Women-Centered Respectful Maternity Care, and this is what I call the heat map. How respectful is our care in Cyprus? Well, you can see that it's work in progress. I know you cannot read, but because I'm not going to show numbers, I'm just going to make a comparison between what we do better, what we don't do as well. And this is an answer to every critic saying that only women with negative experiences might have participated in your survey, which we know is not true, because I can show you later on that the experience we register ranges from very bad to quite excellent. And the demographic profile of the women that participate in the survey in Cyprus, it's pretty much exactly what we would expect from national statistics. So we believe we have a rather representative sample. But even if we believe that there is selection bias, women with negative experiences are more likely to participate in this survey. My methodologist hat, this is who I am. Right? Let's do comparisons. Yes, women do not say that they were treated with discrimination. Very few women say that they felt discriminated against some characteristic. But if we go at the bottom, a very small percentage of women said they always felt valued, they always felt heard. Always healthcare providers make sure that they understand the information given to them. So we have a communication problem. We might not discriminate, but we have a communication problem. We do discriminate too, by the way. Our survey is very heavy on Greek, Cypriot, educated women, 80% with university degrees, like our cohort. Unfortunately, marginalized groups, vulnerable groups, didn't respond to our call as much as we want to. Just a response to why we focus on those groups. We should focus on those groups, because if the experience of educated Cypriot women is this, imagine what the experience is otherwise. Okay, physical abuse, verbal abuse. Yes, only 15%, 1 in 7 women said they were physically abused or verbally abused. If you add all abuse together, it comes to 1 in 3. It's not a problem compared to the heat map, but we should be zero tolerance policy to abuse. There shouldn't be even 1% of women reporting abuse. If we go further down to see where the problem lies, we'll see that a quite substantial percentage of about 35%, so if I reverse it, only 65% of women said they never felt coerced into making a decision. 1 in 3 women felt coerced into making a decision. And if we go further down, bigger problem, we're talking about informed consent. Somewhere here low down is how often, or if always, they felt that their consent or permission was obtained. It's rather low, worryingly low, the women that say always. Even if I don't want to be so strict, and I want to add the percentage of women said, okay, they didn't always ask me, but most of the time they did, we might get a little bit better. But there is a substantial 30 to 40% of women that say, if it didn't happen always, it didn't even happen most of the time. So that is quite concerning. How do we compare with Croatia? Excellently. Here you see a comparative draft, and you can go to our website and see the synopsis of the 2-country comparison. We are much better than Croatia. Croatia is here. Most of the percentages are below 50% of women saying that their rights were respected, those rights of respected maternity care. Cyprus is above 50% for most. So we cannot compare well, but still there is huge gaps. So now I will go, that was the summary. And because I didn't have time to show the results. You can see the results anyway. They will be available openly on the website. It's a Visma presentation, which means anyone at any time can go and click and see the lovely infographics and see the results. I will only choose 2 slides from here and then move on to the video that I told you. Official statistics. It only just came out last week, the latest report. 61% cesareans, 40% are recorded as elective or planned. Lumped together, we currently do not know as a country how many are planned for medical indications and how many are truly elective. Why is it important? Because we often hear the argument that women choose to have a cesarean. Okay? Indicator. 39 weeks or after. Currently, 80% of cesareans are scheduled before or at 37 and 38 week. Episiotomies, the last 10 years is stopping recorded. The latest I found was 2015, 10 years ago, 71%. Rather routine, I would say. Why it disappeared from official statistics in the last 10 years? Nobody knows. It is not reported. It must be recorded, but it's not reported. Okay. I said we participated in the Imagine Euro study just to make us feel proud. Yes, Cyprus is better than Croatia and is better than many other countries. Italy too, Sandra. Italy is down here. Croatia is here. So Cyprus is rather in the middle in terms of how much women say that the care they received is close to the WHO quality standards. But there is way to go. There is many countries above us that the experience reported is much better. We were lucky in one of the stakeholder meetings to have Marcia Lanzerini with us, who is a coordinator of this study. And I think the message we got from that was awareness is the first step. No country is perfect. Unless we agree that there is a problem and we need to improve it, it doesn't matter where you are on this rank, you're definitely not at the top. So awareness is the first step and is where we need to start. Okay, methodology, put it on the side. Yes, validated questionnaires. In Cyprus, we also followed it with focus groups to hear the actual voices. We gave women the opportunity that even if they didn't want to come to our focus groups, to write their experience on the questionnaire, and we analyzed that too. So, a pretty representative sample, I'd say, with what we would expect based on national statistics. No, it's not women that only have negative things to report that participated in our survey. This is the full continuum of the quality of care as reflected by the person-centered maternity care questionnaire that I showed you earlier. 100%, it means that somebody would have said everything was like it should be always, every time. And it kind of measures a deviation from optimal, what we would consider optimal care. If I put the cutoff points in key parts of this continuum, 1 in 3 women have a score above 90%. So 90% close to optimal care, right? But we have 40% that the score deviates quite a bit from what optimal care should look like. And of course, there's statistical associations, differences between districts. I'm not going to name which districts recorded lower scores. The younger the woman, the worse the experience. If she's a first-time mom, the worse the experience. Women who had cesarean section, worse the experience. Women that had complications record worse experience as expected. And this is COVID. Everything got worse during COVID. Okay. Do women participate in decision making? 50% of them say, I felt comfortable participating in shared decision making. The other 50% though, didn't. Associations are the same. First time mom, and now we put a social inequality aspect too. Lower education, lower income, less likely to have a say in the care they receive. Okay, I want to show quotes, and I'd rather show the quotes this way. I know that Irakledia and Prodromoulou were going to join me. They're going to forgive me that due to lack of time, I will do it on my own. I will do it on my own, and please forgive us if there is glitches, technical problems, and so on. This is the first time after a lot of struggle to get this video done, okay? But I want to show you that this video, we didn't just imagine. This is how you use research in practice. This is an educational video that is based on true stories, okay? When standard practice is not practicing standards, we call it. It's going to be in Greek. Please read the English subtitles. And I will pause at key moments. This is Eleni and Andreas.
Εκείνη την ημέρα είχε πολύ κόσμο. Στην αίθουσα αναμονής, η Ελένη ακούει να φωνάζουν το όνομά της. Δεν ήταν η γυναικολόγος της, αλλά σκέφτηκε πως ίσως να είναι κάποια άλλη γιατρός, η Μέα, η νοσηλεύτρια. Την καθοδηγεί στο δωμάτιο εξέτασης, όπου βρίσκονται 2 φοιτήτριες. Αφού ολοκληρώνει την κολπική εξέταση, η Μέα ενημερώνει τις φοιτήτριες πως η Ελένη έχει διαστολή και οι συσπάσεις του κετού έχουν ξεκινήσει. Η Ελένη ακούει τη Μέα να λέει «Βέβαια είναι το πρώτο της μωρό, επομένως μπορεί να διαρκέσει πολλές ώρες». Φτάνει να εξελιχθεί ομαλά και να μην καταλήξει σε καισαρική, όπως η άλλη κοπέλα, στο δωμάτιο 3.
The video pauses anyway, and we've got the WHO quality standards. That sounded pretty normal, right? I don't know, you picked up things that shouldn't have been like this, several, many. I would like to add some quotes. Yeah, I remember the nurse. I don't know, was she a nurse? Maybe she was a midwife. With some exceptions, they were not supportive at all. They changed shifts, and every time it was a different person. And you don't even know their names. Yes, I had a room full of students and a doctor who was disrespecting me, assuming that I don't even understand the language. The students were discussing about me with the midwife, and I listened. This is the only reason I understood what was happening. They were talking about me. They were not talking to me.
Η Μέα δίνει στον Αντρέα και την Ελένη κάποια χαρτιά να υπογράψουν. Το ζευγάρι έχει απορίες και ζητούν από τη Μέα να τους εξηγήσει, αλλά εκείνη τους λέει ότι αυτή η συζήτηση πρέπει να γίνει με τη γιατρό τους. Η γιατρός εισέρχεται στο δωμάτιο και καθησυχάζει το ζευγάρι. Τους διαβεβαιώνει ότι όλα θα πάνε καλά, αναφέροντας ότι πρόκειται απλά για διαδικασία ρουτίνας κατά την εισαγωγή στο μευτήριο. Η Ελένη υπογράφει τα έντυπα και τα παραδίδει στη ΜΕΑ. Γυρνώντας προς τη ΜΕΑ, η γιατρός λέει: «Έχουμε δρόμο μπροστά μας. Θα δούμε πώς προχωράει. Σε μια ώρα περίπου με ενημερώνεις».
Okay, you can read those later on. I would like to continue. We talked a lot about informed consent. Yes, I signed the paper. I had my doubts, but they gave me no other choice. It was such a traumatic experience for me. I had a lot of questions, but I was treated like any of my questions were bothersome. No one explained why they were doing all these checks on me. And it feels strange having to ask all the time. It seems that doctors don't explain so much. And people do not want to know so much. I don't know. This stuff is really, really difficult to negotiate with them unless you really, really, really know your stuff. You have to know your stuff to be able to do that. I think a big part of it is that with my first child, I had not researched so much myself. So I was not aware of the options, which made me listen to only what the doctor said.
Καθώς δυναμώνουν οι πόνοι, η Ελένη αισθάνεται δυσφορία. Ο Ανδρέας της κρατά το χέρι, αλλά είναι ανήσυχος, καθώς δεν ξέρει πώς να τη βοηθήσει. Η Ελένη θέλει να δοκιμάσει την μπάλα του κετού, την οποία είχε φέρει μαζί της. Η Μέα όμως της εξηγεί ότι είναι καλύτερα να μην είναι ξαπλωμένη, καθώς πρέπει να παρακολουθούν τους καρδιακούς παλμούς του μωρού και να βεβαιωθούν ότι όλα εξελίσσονται ομαλά. Η Ελένη ρωτάει αν μπορεί να φάει κάτι, αλλά η Μέα της λέει ότι είναι καλύτερα να το αποφύγει σε περίπτωση που χρειαστεί χειρουργείο. Στο άκουσμα της λέξης χειρουργείο, η Ελένη ξαφνιάζεται, αφού δεν υπήρχε κάποια ένδειξη για καισαρική. Αλλά δεν είπε κάτι.
She, the doctor, kept talking about a cesarean section. I don't like that. I didn't like that way. She scared me. And for me, that was something traumatic. This was my first pregnancy. They were coming in just to examine me. At some point, a midwife came in and I tell her, I would like to stand up. And she told me, no, just lay down on your side. They didn't even give me the option if I want to get up, to walk. My partner was with me all the time, but he was completely overwhelmed.
Μετά από κάποια ώρα, η Ελένη μεταφέρεται στην αίθουσα του κετού. Ο Ανδρέας την ακολουθεί, αλλά του ζητούν να περιμένει έξω, διότι η πολιτική του μευτηρίου δεν επιτρέπει άλλα άτομα στην αίθουσα του κετού. Η Ελένη έχει γεννήσει και κρατά στην αγκαλιά της τη Μαρίλια, το κοριτσάκι της. Είναι πολύ χαρούμενη που νιώθει το μωρό της δέρμα με δέρμα στο στήθος της. Όμως δεν κράτησε για πολλή ώρα, αφού η παιδίατρος ήθελε να εξετάσει και να ζυγίσει το μωρό. «Θα την φέρω αμέσως πίσω», είπε. «Ούτως ή άλλως δεν μπορείς να θυλάσεις τώρα, είσαι κουρασμένη». Στο δωμάτιο νοσηλείας, η Ελένη και ο Ανδρέας περιμένουν με ανυπομονησία να κρατήσουν το κοριτσάκι τους στην αγκαλιά τους. Η Μέα αρχίζει να δίνει οδηγίες στην Ελένη για την περιποίηση του τραύματος. Η Ελένη ακούει με προσοχή, αλλά δεν καταλαβαίνει για ποιο πράγμα μιλούσε η Μέα. Οπότε της εξηγεί ότι την ώρα του τοκετού διενεργήθηκε περινεοτομή.
Okay, let's start from the end. Several vaginal examinations before and after the birth without my consent, and an episiotomy, which I found out after I gave birth when I realized that they were stitching me. The baby was given formula and tea without my consent. The answer was always the same. So you can rest, so we can leave the baby with them. Even though I had clearly stated that I wanted to exclusively breastfeed, a nurse said that I was torturing my child and that I should give him formula. But at least she was the exception, as all the other midwives helped me immensely. I was alone among doctors, nurses, midwives. I didn't even know their names. I'm not even sure if they were midwives or nurses. My husband was not there, not because he didn't want to. He wasn't allowed. It's finishing. It's the last part.
Η Ελένη και ο Ανδρέας κρατούν τη Μαρίλια στην αγκαλιά τους. Είναι τόσο ευτυχισμένοι και εκείνη τη στιγμή τίποτα άλλο δεν έχει σημασία. Η γιατρός και όλη η ιατρική ομάδα είναι πολύ ευχαριστημένοι με την έκβαση του τοκετού. Όλα κύλησαν με ασφάλεια. Το μωρό είναι υγιές και δεν παρουσιάστηκαν οποιασδήποτε επιπλοκές. Συμβουλεύουν την Ελένη να ξεκουραστεί όσο είναι στην κλινική, καθώς οι πρώτες μέρες στο σπίτι θα είναι απαιτητικές, ειδικά εάν αποφασίσει να θυλάσει.
Without any preparation, without any training on what to do next, on how to hold my baby, on how to take care of the incision, on how to breastfeed, on how to position the baby so that it doesn't hurt. After pregnancy, it was a big void. There is really nobody checking on the mother and from the mother and how the mother is doing and what the mother can expect after birth. One of them told me, "We are sorry to see you like this because it should have been the happiest days of your life." So I was made to feel shame for not being happy. So I tried to hide it. It's a shame to remember one of the best times of your life with disappointment because you were treated badly. I think you might have noticed that for the first time they have facial features. Thank you, and please forgive me for presenting the research in this unorthodox way.
So, thank you, Nicos, for your very
Animated speech.
impressive participation in these. I call them peace crimes. I don't know if you agree, because my personal experience is that as a doctor and residents, it was not avoided also us to have this kind of about 40 years ago of this kind of treatment, and this is normal, and it is normal that person like us every time women but also men are eager to took part in a great battle that sometimes is greater than us, than our personal existences. And just in this moment we have to speak about from research to action.
Mm-hmm.
I
must present you.
Yes, thanks.
I am sure that now in your head you have so many things and you wish to talk. Unfortunately, you can do that on lunchtime, okay? So leave them there and you can discuss everything later on. Now, Dr. Sandra Morano, Professor of Obstetrics and Gynecology in University of Geneva, will present to us how we can, let's say, bring research to action, because it's not enough to do research. If you do research and you leave it there, that means you do nothing. So, please.
So very briefly, I belong to a particular generation of women that in the 80s were due to feminism and the social political battles were on the road to search for a different medicine. and we have the opportunity to translate our idealities into reality. In particular, it was a very lucky season for women as me that led some important battles in Italy, just for instance, for the approbation of the Abortion Act that was in 78. But this was only a little step, because the great step was when we were animated by patient entered the first time in the labor world. The labor world is the battle camp for every woman. I am sure that was for midwives, young midwives, and in particular for women doctor. That if you check in every country in Europe and also in USA, are constantly raising as a number. In Italy are more than 60%, and also obstetricians, women are 60%. In USA are 85%. In Croatia, I checked, but I am sure, and also in Cyprus are raising. So, as also was said by in this session, our destiny, in a certain sense, is in our hands. What can I say about my personal, with other women, obviously, experience? We lived with a great sufferance what was in the labor room, and only through research, through our not diseducation, but the education, that is abandoning what we were expected to learn as residents, and going towards other disciplines such as anthropology, psychoanalysis, sociology. We learned another perspective. We didn't know yet Antonovsky, but I personally looked for meeting Sheila Kitzinger. I don't know if you heard a great anthropologist that changed the way of viewing childbirth. And this was the first part of a long preparation together with midwife that arrived to the building from zero of the first Italian alongside the birth center that was launched at the very end of 1999 and became active from 2000. It was a very revolution, because it was a separate little department by only intervention by other colleagues of mine. It was decided with the head of the hospital that particular department had only a midwife for shift and the companion during birth. The pediatrician arrived after at least 2 hours after the childbirth, and all the pathway of the second part of pregnancy was strictly followed by midwives, and we have a protocol in which we checked month by month that the pregnancy was at a low risk. This was important because in this way we have the freedom to have a relationship only with the woman with us. The woman took the family to have a vision of the center, and convince them that all that someone said about this center was not real, because there was a lot of different visions, and also it was not so easy to change way of thinking about birth, because birth was so safe in the hospital. Mm-hmm. Why have a separate department? Because it's so important having the surgery very close. Why to be separated? And we demonstrate that this was the only way to guarantee all the beautiful words in the lesson that are in the lesson of Anna Maria Rossetti, because silence, because no interference, no episiotomy, and not all the things that are in the lesson of Professor Aralkumara this morning were contained in our program. And this is an important moment of great battle that was won by women together. Women, some very little number of obstetricians, me and one or two, and a group of very courageous midwives, and also the women that taught us a lot of things. We learned a lot about the way of give birth without any interference. I think that this kind of achievement is the most important thing in my life so far, and we continued. We can speak tomorrow about other steps that was very easy to imagine and to realize after. So I think that I also another thing, we contributed to open another birth center in Bulgaria that was absolutely out of our imagination. And 10 days ago we went again to Bulgaria to celebrate 10 years of this birth center. Mm-hmm. That was done by a little group of very strong midwives that is called Zebra. And it was for me another great achievement, because when women are decided to be aware, as Nicos said us, all is possible. No other obstacle. I think that this is the lesson of the day.
Mm-hmm. Thank you, Sandra. Now all of us, we must go to have lunch, and then we must be back because we have a lot of things to discuss. Mm-hmm. And another thing before you go, Sandra managed to create a birth center in her country because she found a group of midwives that believe in salutogenesis, believe in their model. Our model, the midwifery model, actually promotes health, promotes nature. Nature gave us the ability to give birth normally, not by cesarean. Only is needed.
Yes, thank you. Thank you.
So one small request before you go to the lunch, or while you are at the lunch. It's very impressive. First of all, I myself, as RespectFul CEO, am very emotional today to see everybody here and all our partners from Europe joining their efforts. There is what we call a maternity hospital bag outside. And during our beautiful campaign that you will hear about, we placed this in different locations, and people and moms-to-be were placing wishes about their birth experience inside. And we're kindly asking you to do the same. There's heart-shaped Post-its and pens outside, and we would really like, before you come back to lunch, to add your wish to the maternity bag. Please, before lunch, back from lunch at 2:20. We'll do almost 1 hour because we adjusted the program a little bit, so we can start on time. Thank you very much.